Ladies and gentlemen, if we can start the session, thank you. So, we're moving on to a session on advances in management of sepsis in thoracic surgery. And I'm very pleased to be able to ask Dr. Maskell to come to the podium. He's a leader in his field as a chest physician working out of Bristol, very involved in the BTS work on some of the pleural disease guidelines I'm sure he's going to be alluding to during his talk, and I'm very happy for him to be here today.
Thank you very much for that kind introduction and for inviting me to talk to you today on the medical management of pleural infection. I think if we take the whole of pleural infection as a whole and treat it like this iceberg, I'm actually going to be focusing in on the medical management of it, which probably is about 9 out of every cases of pleural infection that we see in UK hospitals, and I'll leave the surgical management for our next speaker. I think that most of us know that pleural infection is increasing. There's been a number of studies out, both from Canada and Spain here, showing that over the last decade, pleural infection rates have been increasing by 2 or 3% year on year. And certainly in this American study published in Thorax in 2011, you can see that over the last decade, there has been an increase in the incidence of pleural infection in all age groups. And those incidences have been due to rises in both staph and strep species of pleural infection. So it's an increasingly common problem to all of us. If we look at the sex distribution of pleural infection, there's a bimodal incidence of pleural infection. There's a peak in childhood, which isn't represented on this graph, and then another peak in adulthood in the 6th and 7th decade. And females are less likely to have pleural infection, with a sort of 2-to-1 male to female distribution. These guidelines published by the BTS in 2010 really highlight the cornerstones of management of pleural infection. The first guiding principle is that you need to remove the pleural collection. That can either be surgically or with a chest drain. You need to give them the right antibiotics at presentation, starting with empirical antibiotics and then moving towards targeted ones if you get a causative organism. And something that is often overlooked is the nutritional status of the patient. And people don't necessarily think about that at day 1, and they wait until they're not improving on day 5 and 7, which is a mistake. If we have a look at the medical management of pleural infection, this is the algorithm in the BTS guidelines, and patients that present with a suggestive history of pleural infection with an effusion, we would encourage them to have an ultrasound initially and to sample that fluid. And if there's frank pus, then it's likely that they're going to need a chest drain and antibiotics as a minimum. If it is clear fluid, then actually we recommend that a pH is taken, because that's quite a good indicator if it's an acidic pleural effusion, that they actually won't get better just with IV antibiotics alone and will need a drain of some sort to make them clinically improve. This really is based on good evidence from Hefner's meta-analysis that was published in the Blue Journal over a decade ago now, where over 4,000 cases of pleural infection that were sampled for pH at presentation was stratified. And in this ROC curve, you can see that using a cutoff of 7.2 was a very accurate indicator of actually working out which patients actually would need a chest drain if it was lower than 7.2, or actually that because the pH was still normal, they would probably respond without the need for drainage, just with IV antibiotics. Najraman published in the Blue Journal in 2008 the fact that when you're actually sampling pleural fluid and putting it through the blood gas analyzer, of course you're not going to put frank pus through, but if you're actually putting straw-coloured fluid through, you need to make sure that the syringe that you use to test the pH doesn't actually have air in it, or heparin, or lidocaine, because all of those actually interfere with the pH measurement and make that accurate 7.2 cutoff invalid. If you don't actually have ready access to a blood gas analyzer to get a rapid pH indicator, then we would recommend that you use glucose. That can be sent down to the lab and is quite stable, even if there's a delay in analysis. And the cutoff really for deciding whether to put a drain in or not, if you're using glucose, is 2.2 millimoles. And the ROC curve for that's not quite as good for pH, but it's not a long way behind. I think another important guiding principle is when you've got a loculated effusion, as you can see on this ultrasound, and the guidelines say that you must test the pH to see whether you need to put a drain in. You also need to use your common sense. I mean, this is clearly a highly loculated effusion, which makes it a complicated parapneumonic effusion without you even bothering to take the pH. But if you actually sample that locule there, you'll find that the answer comes back in this instance at 7.3, but all of the different locules will have different amounts of acidity. Some of them might contain pus, some of them might contain just an acidic effusion. And so the pH is a guide towards needing a drain, but it's not an absolute. It's just one extra bit of clinical information that might be useful to you. So what about the microbiology? Well, we certainly encourage that when you're taking fluid and you send it off to the lab, even though the yield is relatively low, it can be increased or almost doubled if you actually make sure that you send some fluid in blood gas in blood culture bottles, as well as actually sending some in a universal container. So in this study by Menzies, published in Thorax in 2011, you can see that the yield increased from 38% to 59% just by using blood culture bottles. The microbiology of pleural infection varies quite enormously depending on whether you are looking at community-acquired pleural infection or hospital-acquired. With the community-acquired, then Strep milleri group seems to be predominant, with another sort of quarter of patients having a streptococcus of some instance, and a lot of them, about 20%, will also have some anaerobic growth as well. In contrast, hospital-acquired infections often have quite resistant gram-negatives, or a lot of them will have Staph aureus. And so the microbiology is very different depending on whether this infection has been acquired in the hospital or the community setting, and therefore the advice is to give different empirical antibiotics at presentation depending on where the patient acquired their infection. We also know that the chances of you dying with a hospital-acquired infection is 2 to 3 times higher than if you actually have got a community-acquired pleural infection, and that also needs to be recognised. So what antibiotics should you use and for how long? Basically, the most important thing is that to actually obtain local microbiological advice, because resistant patterns will vary around the country. A central guiding principle is to avoid aminoglycosides because they don't work in the acidic pleural space. In our institute at the moment, for community-acquired pleural infection, we would use empirically IV ampicillin and metronidazole, and then oral augmentin at discharge. You can use IV augmentin initially, but our trust policy is against that at the moment. And then for hospital-acquired pleural infection, we tend to use tazocin and vancomycin. I'm often asked how long you should keep the antibiotics going for, and we would tend to basically be looking at the CRP, looking at the signs of sepsis such as infection, before we made a decision to switch them onto oral antibiotics. But I would often keep those oral antibiotics going for several weeks in the community after they're discharged. So what size chest drain should be advised to be used? As I'm talking to a group of surgeons, I'm sure that you would favour a very large tube, but there's no good randomised published data to actually back up that suggestion. Probably the best data that we've got is a large retrospective series of over 400 patients that was published in Chest a couple of years ago. And this graph really shows the central message. This is the proportion of patients that were alive and not requiring surgery. And they were split basically into what tube was used at their presentation. And you can see that there's no ill effects of placing a small tube first in terms of requiring an operation or dying at 3 months between the different sized tubes. And the patient comfort questionnaire and pain score that was used in this trial in a large proportion of the patients suggested that if you inserted a smaller tube, then actually you had less pain at insertion and less pain during the time that the tube was in situ. And so although there's not any good randomized data to say that a small tube or a large tube is better than each other, there certainly doesn't seem to be a strong signal that would go against the policy of using a small tube to start with and then increasing it to a large tube in the small proportion of patients that don't actually benefit from the initial drainage. So if we just have a little look at a case history for a minute, just to illustrate the next few slides and studies. This is an 89-year-old gentleman that was on our ward about 6 months ago now. He'd had a tracheostomy for cancer of the larynx, previous history of aspirations, lots of comorbidities. He was very frail, WHO performance status 3 or maybe even 3 to 4, and he presented with a 2-week history of fevers and increasing breathlessness and was found to have a loculated effusion which was sampled. The pH was low at 7 and his CRP was 352. And so he had a 12 French chest tube inserted and was put on IV antibiotics. And on day 3, although he had drained a reasonable amount of fluid, the best part of a litre, he still had quite a marked loculated collection that you can see there on the right side, and continued to be septic with spiking fevers. And the question is, in that situation, what should we do? Do we ask our thoracic surgeons if they're keen on operating, removing that residual collection? Well, with his comorbidities and WHO performance status of 3, they might not be that keen. Do we try some intrapleural fibrinolytic therapy such as streptokinase? Do we put in a second drain at that stage but make it larger and perhaps do it under ultrasound guidance as well? Change over his IV antibiotics, or perhaps try intrapleural DNase and TPA in combination, or undertake a medical thoracoscopy. So those are some options, and now let's perhaps look at some data that might inform us which one of those we should actually do. If we start with the intrapleural fibrinolytics, this basically is a summary slide of the methodology of the large MIST-1 study that was published over a decade now ago in the New England Journal, which looked at 454 patients that presented with pleural infection that had a chest drain in and had acidic pleural fluid or positive microbiology. And they basically were randomized after their tube was in to either having 6 doses of intrapleural streptokinase or actually having 6 doses of saline, with the primary endpoint at 3 months being the proportion of people that actually required surgery or had died. And the primary result of that study was completely negative, so it didn't show that intrapleural streptokinase was in any way beneficial to these group of patients. So that led to the MIST-2 FollowOn study, which basically was looking at the role of a different fibrinolytic agent, TPA, and DNase, and actually looking to see whether actually there was some synergy between those two agents, and actually using both of those agents in conjunction with each other might actually improve drainage and chest radiology. So the trial design of this study was different than the MIST-1 study in the fact that it was a randomized 2-by-2 factorial study, so it was double-blind, double-dummy, placebo-controlled study, and it had 50 patients in each arm. So this is another summary sort of chart of the study. So it was a very similar patient group of patients that were randomized to the study. They all had tubes in, they all had signs of pleural infection, and they got 6 doses of either DNase on its own down the tube, TPA and placebo, DNase and TPA, or double placebo. And the trial design was actually looking at a radiological outcome, and that's important to emphasize. So it's not a hard outcome of need for surgery or mortality like MIST-1. It was actually looking at the radiographic improvement on chest radiograph at day 7. So the actual doses of the drugs used were 10 milligrams of TPA intrapleurally BD for 3 days, and the DNase dosage that was used was 5 milligrams BD for 3 days, and all the placebos were matched and identical to the active product. The actual size of the chest tube was down to the local clinician's discretion, and the antibiotic regime was to fit in with local hospital policy. This is how the primary outcome was actually measured, which is important, and this is just an illustration. So this is one of the patients on day 1, and this is a pacification that they had at the start of the trial, and then this is at day 7. And basically, using a computer program, we could actually work out the percentage change, both absolute change and relative change, from day 7 compared to day 1. So this is the primary outcome slide of that study, and you can see that in all of the 4 groups there was a reduction in the mean change of the hemithorax area, with about a 30% fall in all of the placebo, TPA and DNase group. But in the TPA and DNase combined group, there was almost a doubling of that with a 60% fall. So this was highly significant, p equals 0.002. And you can see that in this summary chart, that this basically is the change in size of baseline pleural shadowing as a percentage from placebo, where this is no change at all, this dotted line here. The TPA group is here, the DNase group here, and then the combined group. So certainly radiographically, this combination seems to work well at improving the chest X-ray, but doesn't necessarily tell you very much about the actual patient improvement. If we have a look at the need for surgery on this side, if you actually drew TPA and DNase, then 2 out of the 47 people actually required to go on and have a surgical operation, compared to 18% for placebo. And very worryingly, if you were given DNase on its own, then actually you had a very high operation rate, with about 40% of patients in that group requiring to go on and have an operation. If we have a look at death at 3 months, again, similarly worrying, very high rate of death in the DNase on its own group at 18%, and no significant differences were noted in the other groups. Hospital stay showed just over 4-day reduction in length of stay if you actually had the combined agent compared to the others. So what is the conclusion of this MIS2 study? Well, I think that it certainly shows that the combination of interpleural TPA and DNase does improve chest X-ray opacification compared to placebo or either agent on their own. And certainly TPA and DNase alone are ineffective, and I would be very worried about someone being given DNase on its own because of the high surgical rates and death rate in that group. But it hasn't really proven that we should be going out and using that first line, because although we've seen a good secondary endpoint and we've seen a reduction in length of stay, we haven't actually got the data to say that it does actually improve mortality and need for surgery. So what about the role for medical thoracoscopy? And I was asked by the organisers just to run through exactly what it is for perhaps some surgical trainees that might not have come across physicians doing medical thoracoscopy in their hospital. It's really done in a very similar way to VAT surgery. It's done in an operating theatre most of the time. Sometimes, if there's the right number of air changes, it might be done in a bronchoscopy suite if infection control are happy with that. But certainly in our hospital, we do it in the day theatre. And the patient will come in and lie on their side, and will just be given normally 2 or 3 milligrams of midazolam and 50 micrograms of fentanyl as a sedation. And we will basically use ultrasound to mark an appropriate point to go in and mark that with a needle. The kit is a Wolf kit, so very similar perhaps to what you will be used to using. And basically, after doing the appropriate cleans, bunt dissection is used with a mattress suture and a port to go into the pleural space to basically drain the fluid and then take targeted biopsies and put talc in if you want to effect a pleurodesis. I think that basically the technique is fairly straightforward, but it is done under local anaesthetic, and basically it is good for trying to diagnose malignancy, but I don't think that medical thoracoscopy has got any role for actually managing pleural infection, where actually if you want to break down the adhesions and actually cure pleural infection, then really that's the remit of the surgeons and not of the physicians. So I would say that there's no good data to suggest that we should be using medical thoracoscopy to actually deal with complicated parapneumonic effusions or empyema, although it does have a role in physicians using it for undiagnosed pleural effusions. We should understand our limitations and not deal with any complicated cases of pleural infection. Although occasionally a patient will come to have a medical thoracoscopy where you are suspecting malignancy, and when you get in you find that it might well be a complicated parapneumonic effusion, but that's a very rare event if you select your patients carefully. So where does that take us with this gentleman on day 3 with his loculated pleural collection and ongoing sepsis? I think that basically it's difficult for the surgeons to offer a full range of techniques with someone who performance status of 3 or 4. but the surgeon certainly could perhaps offer a limited thoracic procedure. Intrapleural fibrinolytic agents with streptokinase hasn't been shown to be effective, so I don't think we should be doing that. And I don't think changing the intravenous antibiotic cover is actually going to improve his collection. And so we opted on the basis of the data that I've already outlined in the MIS2 protocol that this patient was someone that couldn't easily go forward to have an operation, and therefore we would try intrapleural DNase and TPA. And on day 5, he had drained another 1.5 litres, and that's what his x-ray looks like, and he went on to make a recovery and discharged and was fine at 3-month follow-up. So I just wanted to end just by talking a little bit about identifying patients at high risk of death at the first presentation of pleural infection, and whether there's any models that might be useful for us in the future. And just in the way of a backdrop to that last few slides, I wanted just to show you this data, which is from the MIST-1 study, looking first of all at the people that died in the study according to their age range. And you can see that, you know, if you are over the age of 60, your chance of dying of pleural infection in this large UK study went up quite considerably after the age of 60. And if you look at the right-hand graph here, these are the people that got operated on in the MIS1 study. And you can see that a lot of patients got operated on that were under the age of 65, but not very many over the age of 65. And so if we're going to actually try and decrease the mortality of this disease, then maybe we need to concentrate on this elderly group more and either find ways of perhaps identifying them as high risk early when they're not ill enough to preclude surgery, or find some more novel techniques that can be available to this sort of elderly population with their pleural infection. And so with that in mind, there are a number of sort of retrospective studies that have looked at potential markers of poor outcome, and they've used univariate analysis and suggested that this is a poor marker of outcome. But this is the first study that I'm going to present to you now, which is actually being collected prospectively and validated. And so basically we looked at the 411 patients that entered the study in the UK from over 40 centres, and we looked at 32 baseline factors that were available and recorded at presentation for these patients with pleural infection, to try and create, after using multivariate analysis, a risk model that we could then test and validate in a second prospective cohort, which was the MIS2 cohort. So these are the 32 baseline characteristics that were looked at, and the 5 with multivariate analysis that came out as strongly associated with poor outcome were increasing age, a high urea at presentation, a low albumin, a hospital-acquired infection, and interestingly, a non-purulent effusion rather than a purulent one. So we put these together to create something called the RAPID score, and it's been published online and just come out in print a few weeks ago. And the R stands for renal, with a high urea greater than 8 millimoles per litre, giving you 2 points, an age of greater than 70, again giving you 2 points. If it's non-purulent, then you get a point for that, hospital-acquired a point for that, and an albumin of less than 27 another point. And you can put people into low risk, medium risk, or high risk of dying of their pleural infection, depending on whether the score is between 0 and 7. So they're all parameters that should be available to everyone at baseline and fairly easy to obtain. If you actually score 3 or 4, then that's actually associated with an odds ratio of dying of 24.4. And if you score more than 4, then actually it's a staggering 192 odds ratio for death within the next 12 weeks. So we then went on and tested it in the second cohort to see if the model held, and it did. And you can see from these Kaplan-Meier survival estimates that the red line here represents a score of between 0 and 2. So if they score low, they are just not going to die with their pleural infection. If they actually score a high score between 5 and 7, then actually over half of them are dead within 3 months. And so the MIS2 score showed a patients showed a very similar effect using that model. So you could potentially identify patients at presentation medically that were in a low risk of dying, a medium risk of dying and a high risk of dying, and you might well be able to intervene early in this group that might actually help reduce the mortality. But I think that it's important to stress that we're just starting to undertake something called the pilot study, and we need to really evaluate whether this scoring system actually can change outcome. So although it's been validated as a score, we don't know whether actually using that score actually can improve the mortality in this disease yet. So I think that this is my sort of summary slide. I wanted really to highlight that pleural infection is increasing in incidence and still associated with a significant mortality, that certainly patients that present medically, we tend to basically ultrasound them all and obtain pleural sampling early and tend to rely on the pH results as to work out whether we would put a drain in or not. We tend to start with a small drain that's well flushed so that it's patent, which is probably more important than the actual size of it, but we will go to a larger drain if we need as a second line drain. We try and identify poor nutrition at presentation and trying to address that on day one. And we would basically give patients that weren't fit enough for a surgical operation the opportunity to have interpleural TPA and DNAs on about day 3 if they're not responding and they're not a surgical candidate. If they are a surgical candidate and they have failed to drain with those simple manoeuvres, then we would advocate referring them to our thoracic colleagues early on day 3 or day 4, and that there's more evidence to back up that surgery than there is for TPA and DNAs in that group that are fit enough for an operation. So we tend at the moment to reserve the TPA and DNAs for the patients that are not fit enough to go to the surgeons. I don't think there's a role for medical thoracoscopy in empyema. I think that basically surgical treatment of empyema should be done by the thoracic surgeons in that cohort, and I have illustrated that RAPID is the first validated risk score for poor prognosis at presentation. Thank you very much for your time.
We have an opportunity to ask Nick some questions from the floor. I can see a few Bristol thoracic surgeons' hands up. And Ed.
Yeah, not yet Bristol. Thanks, Nick. I've been hassling Naj for ages to do best of mist versus VATS, because on those soft measures, I think VATS would probably prove superior, but I think what we should do is manage them as not worried about which discipline. But if we took a patient very quickly from our chest physician, did a VATS and stabilized them from the post-op ripples, should we say, and then they went back to a respiratory ward, if it looked like they might not be, making quick progress, that would, I think, facilitate your surgeons taking more patients.
Yeah. So, I mean, I totally agree with you that that is a trial that's waiting to be done, and I'm also putting some pressure on NAJ to perhaps make MIST 3 that type of trial. The problem is that it has to be very robust protocol-driven trial, and that is difficult when patients actually are being treated by surgeons in one arm and physicians in another arm. And so I think that perhaps a best model for that would be to perhaps have them under the physicians initially, and basically on day 1 have the drain put in, and if they've got a loculated collection, then they get randomized, if they're fit enough, to either come directly to you for a VATS and then back to us, or to have 3 days worth of TPA and DNAs, and I think that would be a great study to do.
Doug.
From our perspective, we see a huge amount of work that's been done on pleural sepsis in the medical context. And yet surgery is an endpoint, and there's very little done to look at what operation's right and who should have what operation. What trials should we be doing in surgery? And if you had pleural sepsis, what operation would you have based on what we know today?
Well, I think that's very difficult. What's quite interesting from the data that we've got is that even just doing nothing, the placebo group do have an improvement radiographically and also clinically in a proportion of patients. So you saw that there was still a 30% improvement in the placebo arm of MIST 2 showing that their chest x-ray had improved. And there are a lot of patients that actually I have said, I think you need an operation because you've got a residual collection, and they've adamantly refused, and we've carried on treating them with prolonged antibiotics, and their x-ray 6 months down the line completely goes back to normal. And so when we're dealing with a disease that on the one hand can do that, and on the other hand you can have a young 22-year-old that has pneumococcal sepsis that basically, you know, is not responding to medical care and needs an urgent operation on day 3, it's quite difficult to design a trial that is going to actually incorporate all of those findings, because people seem to go down that pleural infection cascade from simple parapneumonic effusion, you know, down to complicated parapneumonic effusion at very different rates. And so I think that in answer to your question about what operation, I think if I would prefer to have medical management first, and if I did need an operation, I'd probably opt for a surgical VATS operation. But in terms of what studies you should be doing, I think that I would encourage us to do a randomized controlled trial that has a surgical arm, such as MIST-3.
So Nick, on the basis of your rapid scoring system, should we translate a high-risk rapid score as equal to early surgical intervention? And in that sense, will that be the next iteration of the BTS guidelines?
Yeah, no, I think you have to be quite careful, because all we're showing is that that group of patients don't do very well. And you could say this score is just showing crumble factor. And actually, it's not got as much relevance to the cohort of patients that you might see that you want to operate on. But certainly, I think from a physician's point of view, whether this patient is fit enough for an operation or not, if we know on day 1 that actually they've got quite a high chance of dying of this disease process, then potentially it might encourage us to do more invasive medical therapy early on, get you involved early on, rather than basically waiting until day 10 or 14 when, you know, their albumins drop further and their performance status is even poorer. So I think we're a long way from proving that we should really use rapid, but it's a step in the right direction.
Any more questions from the floor? I have one last question. MIST-1, remind me, Nick, was 2005?
2003, yeah.
Yeah, and what you mentioned about the surgical mortality in the subsequent analysis of that trial, what operations were being performed on those patients?
Yeah, it was a range. Obviously, there wasn't as much VAT surgery that was being done. There was quite a lot of minimal surgical intervention, so a rib resection and washout, and there was decortication for a vast, you know, for the large majority of what's left. So it was a range, but a lot of them were not full decortications.
Thank you. Thank you.
Okay, thanks.
So